Good evening, everyone. Welcome to our first of this year, the California ACC Prevention Committee Prevention webinar. So tonight we have a very excellent talk on the guidelines, the new guidelines that come out, which are one of the landmark papers that have come out in several years. The guidelines on dyslipidemia came out just in March of 2026. And we're going to be discussing those with all of you. Just for a couple of thoughts. So you'll see on the bottom of your screen a chat box, so you can put in any questions you have anytime during the presentation. We'll have a Q&A session after Dr. Wong's talk. And in addition, you can make sure that if you'd like to, at the very beginning, you can say where you're from and what your organization is if you would like. So my name is Dr. John Baker. I am an invasive interventional cardiologist at Anaheim Regional Medical Center. Have many hats. I'm also the treasurer and also the incoming governor of Southern California for the California ACC. But my major hat today or tonight is the co-chair of the California ACC Cardiovascular Disease Prevention Committee. I would like to introduce Dr. Wong, who is our speaker tonight. Dr. Wong is also the co-chair of the California ACC Prevention Committee. Dr. Wong has an extensive list of accomplishments. He's actually dedicated most of his professional career to prevention and also to lipid therapy. He is the director of prevention at the University of California, Irvine. He has written many papers, textbooks. He's participated in multiple trials over his career, and he's here to talk to us, and he's the past president of the American Society for Preventive Cardiology. So he's going to talk to us tonight about the new guidelines, which are essentially, as I mentioned, one of the things that, if implemented, is going to be life-saving and morbidity preventing in multiple different patients throughout its term. So without further ado, I'd like to introduce Nathan Wong. Take it away.
Okay, thank you very much, John, and a pleasure to speak to this group again. And so I think, as everyone knows, the guidelines just came out in March. The new guidelines are first since 2018, and it used to be called cholesterol management guidelines, if you remember. And so it was quite a process to change it to dyslipidemia, because certainly there's more to lipids than I'm actually just cholesterol. So the guideline committee managed to get them to change that. So these are some actually disclosures I have, and also acknowledging the source, the actual guideline publication, and a bunch of these slides came either from the AHA or from my close colleague, Dr. Blumenthal, who chaired the guidelines. So we'll go through this. So to begin, I think everyone should know about, life's essential 8, right? So following healthy lifestyle patterns is the foundation of prevention, and throughout the lifespan, we need to be aware of these 8 characteristics as listed and make sure that they're controlled, because that will, of course, reduce your overall absolute risk. Our guidelines focus on the patient-clinician risk discussion, which should emphasize helping the patient understand their cardiovascular risk. Also, you have to emphasize healthy lifestyles, a foundation for risk reduction, talking about different potential risk and benefits of therapies. This is not done enough. So this is why we have suboptimal use of many therapies, even in particular statins. And then, of course, there's cost considerations, frequency of administration, and patient preferences, right? Play a big role into this. So it's very important. It's a shared decision making issue when we're talking about preventive therapies. We're not going to be focusing on lifestyle tonight. That will be the focus of a future webinar in the near future, actually. So you will hear about nutrition in a few months. But just to remind people, it's a class one recommendation to follow basically what's a DASH Mediterranean type diet, emphasizing intake of fruits, vegetables, nuts, legumes, whole grains, and fiber, replacing saturated and trans fat with monounsaturated and polyunsaturated fats. And then, of course, physical activity, right? 150 minutes a week or more of moderate to vigorous intensity physical activity, as well as resistance training. This is all part of emphasizing cardiovascular health. Certainly stress management is very, very important, and that's a whole nother discussion. I also want to remind people that in our new guidelines, it's not recommended to use dietary supplements because their evidence is very limited. In particular, there's little evidence to support them for reducing cardiovascular risk. So we have to be very careful about dietary supplements, and this should always be part of the risk discussion, right? Making sure our patients understand that, it's our proven pharmacologic therapies that have significant evidence for cardiovascular risk reduction. There's a big focus on reducing lifetime exposure to elevated LDL, right? So we need to start earlier. And now there's a recommendation that all adults with heterozygous familial hypercholesterolemia and those who are 30 or over with persistently elevated LDL, strong family history of ASCVD, or high 30-year risk should be on a statin. And a lot of the rationale for this comes from studies like this one from Anne-Marie Navarre in Texas, right? Showing that the number of years of exposure to high cholesterol is directly related to the patient's risk. So you can see that over 15 years in someone who had more than 10 years of exposure to high cholesterol, their cumulative risk of coronary heart disease was close to 17% compared to only 4% if they were newly diagnosed. The prevent ASCVD risk equations are central in the new guidelines, and we have this concept called CPR, right? So the new definition of CPR is calculate, personalize, and reassess, right? So we have to calculate risk, and we'll talk about how we do that with the new scores. We have to personalize it with risk enhancing factors and possibly also coronary calcium. We'll talk about that, and then that really helps reassess the need for lipid lowering therapy or reclassify as well, so the person's risk. So and what's new here, compared on the right-hand side of the screen, you'll see that compared to our prior pooled cohort risk scores, we have new categories of risk, and we'll kind of talk about the rationale for that. So low risk in the older scores, the pooled cohort risk scores, was less than 5%. It's less than 3% for prevent ASCVD. In addition, borderline is now 3 to less than 5%, intermediate 5 to less than 10%, and high is 10% or greater. You can download from your smartphone the ACC CVD Risk Estimator Plus. Okay, so everybody should be doing this because it's easy now to put in the required numbers to calculate your 10-year and 30-year risk, not only of ASCVD, but also heart failure and total cardiovascular disease. And then the Risk Estimator Plus also gives treatment advice based on the guidelines. So it's very, very useful, and it can be a valuable aid when you see your patient. This is an example of what the calculator looks like. So, you have to enter the usual risk factors, but now we require body mass index, and EGFR is also a required component. So you need to know those numbers, and most patients will have an EGFR calculated in their actually medical record. We no longer use race and ethnicity. This was taken out. It was felt that, we shouldn't simply be assigning risk based on the color of a person's skin. But we do instead have, so the baseline model inputs are shown there. And as I said, BMI and EGFR are required. And it does calculate not only CVD, but ASCVD and heart failure for both the 10 and the 30-year time frames. There are some limitations as to the age that you get these calculations, however. And then, importantly, you can further refine risk prediction if you have the urine albumin creatinine ratio, A1C, as well as zip code, which is used as a social determinant of health. So because I live by the beach, my prevent risk score actually, without the zip code, would have been 8%, but it goes down to 4.9%. And then, remember to calculate, personalize, and reclassify. That's a new definition for CPR, right? So you calculate your risk. If you're at low risk, it's mostly lifestyle modification that you will consider, right? If it's borderline risk, you evaluate these risk enhancing factors that we're going to talk about to further help in your decision and the patient's decision whether to start therapy. And we can also use coronary calcium score, both for the borderline and intermediate risk patient, to kind of tailor the intensity of therapy. And we're going to talk about that in a few minutes. The high risk group is definitely indicated for both lifestyle modification and lipid lowering therapy. Again, as we'll talk, if the person has a very, very high calcium score, more aggressive targets. So part of that rationale for the 3% for considering lipid lowering therapy comes from this panel A on the left. The idea being that a moderate intensity statin, you would have to treat 100 people to potentially cause one case of diabetes, okay? Because we know that from the clinical trials, which mainly enrolled people, many of them had pre-diabetes to begin with. So but the glucose does rise, right? So there is a very slightly greater risk of developing diabetes from a statin. That risk is a little greater with a high intensity statin. So every 33 people treated potentially might get someone over that somewhat arbitrary 6.5% A1C threshold. But the idea is that the red curve indicates the number needed to treat to prevent an ASCVD event. So wherever you are, where these lines intersect, right, is where that's a cut point for what we call the net clinical benefit, right? That's where the benefit outweighs the potential harms. So it's 3% at a moderate intensity statin. At a high intensity statin, it's closer to around 7%. And of course, just to remind people, because this isn't done enough, clinicians aren't spending enough time, talking to the patients about the benefits of of statins, and they read a lot on the internet about the potential harms. In fact, one can search risk of statins, and a lot more hits come up than actually benefits. So we need to educate our patients about the wealth of clinical trial evidence over the years showing the benefits. The risk enhancing factors are important, and we now have a somewhat expanded list. So in addition to premature family history, higher risk ancestry, South Asian and now Filipino is added to the list. Also, probably individuals of African American ancestry we know are at higher risk too. High polygenic risk, okay, from a polygenic risk score, and we also have chronic inflammatory diseases, cardio kidney metabolic syndrome, okay. And some of you may have heard that this yesterday, the American Heart Association released a new guidelines for clinical management of cardiometabolic syndrome. So this is this is important, maybe even more important than the new dyslipidemia guidelines that came out. So we really need to get that better communicated to the clinician community as well. We'll talk a little more about reproductive risk markers on the next slide, but also certain biomarkers like elevated hsCRP, triglycerides, persistently elevated LDL, ApoB, and increased levels of lipoprotein little a that we're also going to talk about. So if you have risk enhancing factors, it really favors considering statin use in borderline to intermediate risk individuals. So that's a 3 to less than 10% category. Looks like it's not my dog, so someone else's dog. Okay. Anyway, reproductive risk markers. Okay. So this involves adverse pregnancy outcomes, which we know are associated with an increased risk of cardiovascular disease. So hypertensive disorders of pregnancy, such as preeclampsia, gestational diabetes, small for gestational age birth weight, preterm delivery, spontaneous pregnancy loss, and other reproductive markers like early menarche, early menopause, and PCOS. So the clinician needs to ask their female patients about these reproductive risk markers, and not everybody is doing that, because this can also inform for earlier and more possibly more intensive treatment, because these individuals are going to be at higher cardiovascular risk. So we talked about the different risk score categories already, right? Low risk under 3%, borderline 3 to less than 5, where you may consider statin therapy, particularly dependent on these risk enhancing factors. Intermediate risk, where it's a more definite decision to consider therapy. And then high risk, it's almost for sure. LDL goals are back, right? So we now have, for most borderline to intermediate risk individuals, an LDL target of less than 100. High risk individuals, this includes most people with diabetes who have additional risk factors, heterozygous FH, also a calcium score of 100 to 999. But I think many of us would say if you're 300 or higher, as you can see at the bottom, as well as greater than 1,000, you should definitely have a more aggressive LDL target, probably under 55. Most patients with ASCVD, we'll cover this later, are very high risk and should be treated to an LDL below 55. Very important that you also think about non-HDL targets, and this is simply not on many people's radar screen, and these are 30 points higher. Okay, so if your lab slip is not reporting a non-HDL, and most do not, that's an easy calculation. Just subtract the HDL from the total cholesterol. And that's important because non-HDL encompasses all the ApoB containing lipoproteins. And we also now have ApoB targets. Okay, apolipoprotein B is the most strongly related to risk of these three lipids, but we are, of course, used to treating LDL, and we need to do a better job with this reaching LDL and non-HDL targets in selected patients. I'll talk about this. So here, you could consider ApoB, particularly in people with CKM, diabetes, or elevated triglycerides. And these individuals are more likely to have suboptimal ApoB levels, even when LDL and non-HDL goals have been met. So primary prevention, we talked about this, focuses mainly on lifestyle, but in someone who is low risk, who has persistently elevated LDL cholesterol, you could consider statin therapy. Borderline risk, it's reasonable. Think again about those risk enhancing factors. And it's a class 1 recommendation already if you are at intermediate risk, 5 to less than 10%. And a goal, and you also want to get that non-HDL under 130, and in these intermediate risk people to go, and borderline risk people to go LDL would be less than 100. In high risk people, we want to treat more aggressively and using a high intensity statin from the outset, and an LDL cholesterol goal of less than 70. Consider an adenozitamide, and if you still are not at goal, consider adding a PCSK9. You could also consider inclisiran for those that may not adequately respond or tolerate or adhere to a PCSK9. That also lowers LDL in the 40 to 50% range. And bempedoic acid is also underappreciated. Remember, this was studied in the CLEAR Outcomes trial and showed ASCVD benefit in people that were primarily statin intolerant. So it does provide approximately 15 to 20% further LDL cholesterol reduction. Lipoprotein(a), something I'm very passionate about, and in the future I'll do an update talk on this. But this we know is one of the most powerful genetic factors for cardiovascular disease, particularly coronary heart disease and aortic stenosis. And in general, if you're above 50 milligram per deciliter, remember some labs do measure it in nanomoles per liter. There's not a really recommended conversion factor, but approximately it's going to be 100 to 125 nanomoles per liter. And then if you're at higher levels, around 100 milligram per deciliter, you got a 2-fold risk, and 4-fold risk if you're at 180. So it is now recommended to measure it at least once in all adults. Okay, this is officially now in our U.S. guidelines. It was not until this past March when this guideline came out. And many clinicians will say, well, why should I measure it if I don't have therapies to lower it yet? Now, we do have LDL apheresis, but that's a very laborious procedure and not widely available. But the point is that increased LP(a) identifies people at higher cardiovascular risk. So we really need to optimize all those risk factors, right? So it's not just about lowering LDL, it's about better control of diabetes, hypertension, getting the person to stop smoking, really focusing on those life's essential 8 that I showed at the beginning of the talk. And certainly there's a wealth of data, particularly showing relationships to a wide range of cardiovascular outcomes, but in particular, MI and aortic valve stenosis. And our published pooled cohort study in more than 27,000 adults followed for over 20 years showed roughly about a 6% higher risk if you were above the 90th percentile. That was in the 50 milligram per deciliter range. And risk were stronger for MI and revascularization, and also for people with baseline diabetes. Although I will say that's not a consistent finding across studies, but we showed it. So again, the focus is on reducing the person's global risk, right? So you can see in the blue bars, someone with an LP little a of 150 milligram per deciliter, right? Their lifetime risk is substantial, right? It's 68%, but if you lower their burden of risk factors, you can reduce that lifetime risk to only about 14%. Obviously, if it's not that elevated, the lifetime risk is less. And the absolute risk reduction from optimizing risk factors is also less. Um, so, um, so that's, so the point here is that, lowering the person's overall global risk by management of all risk factors is what you need to do in someone with an elevated LP little a. We do have promising therapies this around the corner. The first pelacarsen is going to be reported out, we expect later this summer, from the Horizon Outcomes trial. And hopefully that will be positive and will set the mood for the others to follow. So as I said, optimal control of all our modifiable risk factors in everyone, right? But in people with clinical ASCVD who have elevated LP little a, if you still need to optimize LDL, you could consider a PCSK9 inhibitor. That's in the guidelines because we know that those do lower LP little a by around 25% or so, even though it's not in their labeling to lower LP little a, but they can be used. There's some evidence from the outcomes trials that some of the reduction in risk is due to their lowering of LP little a. How about coronary calcium? So this has been something I've been involved with for more than 35 years, did some of the early pioneering work on this. And in this statement that I was part of from 2024, we stage disease based on the amount of calcium present, right? So just like how we stage heart failure, you can stage atherosclerosis. And the higher this, and because ideally, if you stage disease, it becomes more actionable, right? So people with higher stages have more aggressive LDL targets that we had recommended in the statement, such as below 55, if you were 300, or higher, and particularly above 1,000. And this is basically what the guidelines provided, essentially the same recommendations, right? So you can see here the optional LDL goal of less than 55 if you're 300 to 999. Even if you are 100 to 299, you should have your LDL below 70, right? And then extensive disease, right? 1,000 or higher in LDL target below 55. And incidental, what's really exciting is, and this I did not expect, but they actually provided guidelines for incidentally detected CAC from non-gated CT scans. We have a great opportunity in America from the 19 million or so non-gated CT scans done for other reasons, such as lung cancer screening. But very few of these people would know their cardiovascular risk and be evaluated for it. But now we have an opportunity, and there's AI tools and others that allow for quantification of CAC. What the guidelines say is that if you have mild CAC, so probably in the 1 to 99 range, or it's just designated as mild by the radiologist and not scored, then do consider an LDL target below 100. If you have moderate to severe CAC, and a lower LDL target of less than 70. So it was really amazing to see that. And I will say that CMS, as of April 1st, approved reimbursement for opportunistically measured CAC from non-gated CT scans. So this pretty much reiterates what I said, right? The higher the CAC score, the lower the LDL target. And the incidental CAC and the CMS approval. There are some recommendations, although not too strong, that certain populations of patients, such as those with inflammatory disorders, HIV, diabetes, you could consider CT angiography to further inform risk assessment, but it's not nearly as powerful a recommendation as a class 1 recommendation we have for coronary calcium, now that there's now decades of data on outcomes and how it can identify people most likely to benefit from statin therapy. We also had a recent statement from the American Heart Association I was privileged to be a part of, where we discuss the opportunistic use of calcium detection from the non-gated CT scans, given that you can use the existing scans. So no additional imaging, radiation, or charge by doing another scan. And we can now accurately quantitate coronary calcium from these non-gated scans. So I just wanted to point out this rather unique and important advance that the guidelines highlight. What about other populations, right? So generally, statins are recommended for most CKD patients, HIV and diabetes, also cancer patients. They're not recommended for pregnant patients. We'll say a little bit more about this. So people with stage 3 or higher, generally you can consider statin use if they also have ASCVD, in particular high intensity statin if they also have ASCVD, and really trying to get that LDL below 55 in those with who require maintenance hemodialysis. You could consider continuing any statin use because these patients also have an increased risk of ASCVD. So remember, it's not really for the CKD, but that they are at higher absolute risk of ASCVD. Diabetes, right? So for the uncomplicated diabetes patient without other risk factors, the guidelines do say an LDL below 100 is okay, but most of these patients will have multiple risk factors. And so we want to consider a high intensity statin and, if necessary, other therapies to get the LDL below 70. And very important, and this came out yesterday, so I made a slide on this afternoon, and people need to be aware of this, the management of CKM, right? So new guidelines and new things that we need to be aware of. And the main take-home message here is that, and they basically mimic what's in our dyslipidemia guidelines that I've been discussing, right? But they do point out that, dependent on your prevent ASCVD risk, right? That helps inform statin therapy, and we should be calculating that. And there's a lot of people. There's a large percentage of the population has stage 1 or stage 2 CKM based on having abdominal obesity or overweight or elevated metabolic syndrome risk factors such as high triglycerides, low HDL, hypertension or elevated glucose. So a large percentage of people are in stage 1 or stage 2, and we should calculate the prevent risk score, and dependent on that risk score, consider lipid-lowering therapy. They do point out in stage 3, this is where you have subclinical atherosclerosis that pretty much aligning with what I just showed you, that people with clinically significant CAC should be considered for initiation or intensification of preventive therapies. And it's not just statins. We now have evidence that people with increased CAC, because they have a high absolute risk of ASCVD, they're going to have a lower number needed to treat. And not just for statins, but also aspirin, GLP-1 receptor agonists, and there's also some evidence they'll more likely to benefit from antihypertensive as well as other therapies. Adults with HIV do consider statin therapy. These individuals are at increased ASCVD risk, and there are some data, such as from the Reprieve trial, on this. People with a history of cancer should be treated similarly to those without cancer in terms of statin therapies, unless there's a concern for specific drug interactions. And then finally, people who are pregnant or lactating, it is recommended to stop statin therapy 1 to 2 months before attempting to become pregnant. And you could consider lipoprotein apheresis in those with homozygous FH, and also fibrates or omega-3 fatty acids could also be considered for those pregnant patients with severe hypertriglyceridemia, and that's also mentioned here, and in people with FH or who have a history of clinical ASCVD. If they're already on statins, it may be reasonable to continue it as well. Older adults are actually given somewhat less certain priority for intensive treatment, and I'm not sure I completely agree with that. One of the things is we shouldn't just be using biological age, right? So there's people that are 75 or 80 that are physiologically, biologically more like maybe a 50 or 60-year-old. So you have to take those into account, right? And certainly the concern of frailty in some patients, functional status, and polypharmacy, these are all important considerations. So it is important to think about these guidelines, but again, it's your clinical judgment, and if you have an older patient who you believe is at high cardiovascular risk and who can otherwise tolerate the therapies needed to get their LDL to the recommended targets we discussed, you should consider that. And we do have evidence of benefit in older people from statin trials. Obviously, there's somewhat less evidence for non-statins. So important when we're talking about ASCVD patients, right? We classify these individuals either very high risk or not at very high risk. Most ASCVD patients will be at very high risk because they have two or more major ASCVD events, as shown here, right? Recent ACS, history of MI, stroke, or symptomatic PAD, or one major event, or two or more high-risk conditions, such as advanced age, bypass or percutaneous intervention, smoke and diabetes, history of heart failure, hypertension, or elevated LDL. Now, most clinicians may not necessarily want to count all these factors, but it's just important that you understand that the official guideline is, less than 55 for most ASCVD patients who are at very high risk. A small minority will be not at very high risk and maybe suitable for an LDL goal of less than 70. And don't forget about at least the non-HDL goals. And we just talked about how you define that very high risk status. Very high risk ASCVD patients have a 3 to 5-fold greater recurrent event risk than those who are not at very high risk. So again, when you're talking about different therapies, right? We still have the stepped care approach, right? We start with statins, and if you still need further LDL lowering, to consider either ezetimibe, a PCSK9, and or bempedoic acid is now in the guideline. And this can help you achieve target. Now, I think where these guidelines are somewhat limited is that we really should be like we do with hypertension, right? Starting with perhaps combination therapy from the outset, depending on how much LDL cholesterol lowering is needed, right? And like we do that for hypertension, right? We start with the fixed dose combination if you're 20 millimeters of mercury systolic or 10 diastolic above target. So I think that is certainly something to consider, right? It's not pushed by the guidelines, but but we know that a lot of people aren't getting to target. And then the other thing I'll comment on is that our European guidelines, in someone with recurrent events, these are extreme risk individuals as defined by the European guidelines, and they specify an LDL goal of less than 40. And for South Asians, I'm involved in the recommendations for them, actually India, and we recommend an LDL below 30 in these extreme risk individuals. Because South Asians are getting coronary disease about 10 years earlier than most other groups, despite similar LDL levels. So obviously their LDL levels are probably too high. So again, the statin is used as a foundation. We can add ezetimibe or bempedoic acid or a PCSK9. Inclisiran can also be considered, and certainly, especially when the PCSK9 is not tolerated or it's difficult to get. We are waiting the outcome data on that. In the next couple years or less, we may have some of the first outcome data demonstrating whether it does show cardiovascular benefit. So it's likely that if it does, it's going to be put on the similar footing as the other non-statin therapies. Many patients are not getting to go on statin monotherapy, right? Only 70% are getting to below 70. But the combination therapy, you add ezetimibe, that goes up to 86% and 99% if you add a PCSK9 inhibitor. So this is why we got to think more about combination therapy, and non-statin therapy is terribly underutilized. We see this in our own data across the University of California system. Still, 23% of men, 29% of women not on any lipid-lowering therapy. These are ASCVD patients, and 31% and 22% only were on high intensity statin, and quite very few were on the different non-statin therapies. So there's a lot of clinical inertia issues there. Lastly, hypertriglyceridemia, and lifestyle management is the foundation for taking care of elevated triglycerides, including referral to a registered dietitian nutritionist. Don't forget that they're important resources to get better adherence to diet, and the Academy of Nutrition and Dietetics, the A&D, which few physicians know about, has terrific resources that should be consulted. And then finally, with certain medications, right? People with moderately elevated triglyceride levels, we know from the Reducer trial, has cardiovascular benefit from icosapent ethyl. So this can be considered. The combination DHA EPA preparations do not reduce risk. It's only the pure EPA icosapent ethyl. Very, very high triglycerides. Also, you can consider these therapies, but in certain cases, like those with familial chylomicronemia syndrome, where the triglycerides are frequently 1,000 or higher, you will need one of the newer FDA-approved ApoC3 agents, such as olezarsen or plozasiran, that to control the triglycerides and help prevent pancreatitis. So we covered a lot. In summary, just want to remind you, lifestyle management is still the foundation for dyslipidemia management, so don't forget about that. The CPR approach: calculate, personalize, and reassess it should read the patient's eligibility for statin, and what the LDL goals should be, right? So the goals are back. We're happy to see that, because when they were taken out in 2013, and I remember that day, that afternoon when the guidelines came out, I was lecturing and people saw it come across the internet, and they were shocked, right? We had taken goals out, but now they're back in, right? So it's a lot more actionable. Less than 100 for most primary prevention, low risk patients, less than 70 for higher risk primary prevention in most diabetes. And the relatively few patients with ASCVD not at very high risk, and less than 55 for those at very high risk. Use non-HDL, and in selected patients, you can consider ApoB, as we discussed, to further optimize treatment. But we do need to move towards thinking about non-HDL. And then finally, measure Lp(a) in all patients at least once, and reduce global risk in those found to be elevated. And you can consider a PCSK9 for those needing further LDL optimization, particularly if they have ASCVD. So again, get with the guidelines or get eaten. And that is the end of my discussion, and happy to entertain some questions or comments.
Thank you, Nathan. That was terrific. That was a great presentation of 134 pages of guidelines. So you did a great job of distilling that into words that we have. I have a question for you. So essentially, we're looking at the data that shows that a very low percentage of clear atherosclerotic patients, ASCVD, have treated less than 70 or less than 55, a staggering number of people that are just not being treated. So we have a lot of ways to go. So we have a long ways to go. The guidelines have come up with something that will say that how we can do this. So just for a clinical example, just say you have two patients. One Both of them are just 55 years old. One of them has no risk factors. One of them has no known risk factors, I should say, and then the other has hypertension and maybe a family history of heart disease. Both of them are concerned about the risk of atherosclerotic disease in the future. So, with the litany of tests that are available to clinicians nowadays, what would you order for both of those patients in terms of assessing what their risk is? And, there's lots of tests we could do. So, I'm just getting your comments on what battery of tests would you order besides a standard lipid profile?
Well, so I think, first of all, remember that many of much of the information about the risk enhancing factors are available, so we should first look at those. But certainly the Lp(a), we talked about that, and there's a fair amount of data that can further up stratify a person's risk for indication for lipid lowering therapy. You said a 55-year-old patient, right? So they're certainly a candidate for coronary calcium screening, and someone with a family history in particular is more likely to have coronary calcium that could be an impetus for more intensive treatment. So those are some of the factors. Sometimes you can more precisely estimate someone's genetic risk using a polygenic risk score. So remember, that's in the guidelines. But those some of those tests are proprietary, and they're fairly expensive, from my understanding. And I think again, we need to calculate the person's risk, right? So remember the CPR framework, right? Calculate their risk, use that as a starting point, but we do have to think about these risk enhancing factors. And certainly, lipoprotein(a) is now recommended, for everyone to be measured.
Great. So got it. So, but you would not treat those two patients differently. So one with two risk factors, one with zero risk factors. You would still order your battery of tests with both of those.
Well, yeah. So the person with zero risk factors, wait, that person didn't have a family history either, or?
Correct. No family history.
Yeah, but 55-year-old, yeah. Well, I think part of the problem is that, people are falling through the cracks with this, because many individuals who get coronary disease, and there was a nice report that came out not too long ago, and I can't remember the exact numbers, but something like 40% or so of people who were admitted for a myocardial infarction did not have the traditional risk factors, or were at low risk this 2 days before their MI. So people are falling through the cracks, and this is where we need to do a better job. And while the risk scores are a start, right, we need to be taking a better medical history, right, of our risk enhancing factors, and including the pregnancy and reproductive risk factors that I talked about for our female patients. So we just need to do a better job. And like even family history, right? I always say how it's not a simple yes, no. You don't just ask your patient, do you have a family history? You ask them when they got their event, or when there was it a first degree relative, an uncle or an aunt, or a father or mother, and when they got their event. And so you have to quantitate it. It's a number of first degree relatives that matters and when they got their event. So you need specificity in family history that is not oftentimes done.
Outstanding. So anyone who has any questions, feel free to ask them. You have one of the nation's experts right here in front of you. So if you have any questions, feel free to ask. One other question. So, statin intolerance is something that's coming up a lot. So people just don't want to take statins. Do you ever see a day when um, other drugs may be used as primary treatment for hyperlipidemia, rather than statins as they are now as being the primary treatment for hyperlipidemia?
Well, I think in most of our recommendations, right, say maximally tolerated statin therapy, and we should always try that. But there are patients that will absolutely resist taking statins, right? But they will consider one of the non-statins. So certainly, that's a worthwhile that you should give them one of the other therapies if they're willing and if they can tolerate it, but I think because statins are generic and they're literally pennies a day, that's partly why they're first line therapy. So you may see things when these therapies, when the newer therapies become generic, right? So it's this a matter of several years before some of our PCSK9 inhibitors will become generic. And ezetimibe is always already generic, although I have mixed feelings about ezetimibe because the outcome data was in a very high risk population and it only showed a 6% relative risk reduction, which, is not great, but it's in the guidelines because it was a statistically significant result, basically. So we have a question from Hattie Hanley, and thank you so much for joining tonight. Why not do CAC on a 40 or 45-year-old as a screening test if 40% are not caught before their MI? So it is, in the guidelines for men over 40 or over, or women 50 or over, but in much younger people, you will have the the issue where they could have atherosclerosis that's not yet calcified. So this is why we don't recommend it in younger people, not to say they won't have calcification. And you're completely right that some will have a very strong family history and they may have calcification. And we do see, actually, what's interesting is that there are studies in for example, adolescents with FH, where you do see calcification at a younger age. Okay, but there are other tests, and there is a statement about considering carotid plaque, right, from carotid ultrasound, and that's also in the European guidelines, although coronary calcium is still the preferred test because it has the most evidence. But and then we can also catch increased carotid intermedial thickness in younger individuals, much younger individuals, although that's not currently in our guidelines to, stratify treatment. Like, we don't say if you're above the 75th percentile for your carotid IMT or you have 1 millimeter or more, we don't say you should have a certain LDL target. And because, there have been issues from meta-analysis where carotid ultrasound, carotid IMT did not significantly improve net reclassification improvement. Comment from Dr. Alani, right? Thank you for attending.
Regarding statin benefit, if a calcium score is 0, but a high LDL without a high lipoprotein to lake.
Okay. Well, Yeah, so again, yeah, we have to look at a person's overall global risk, right? So I'd like to know if like the age of the person, if they have diabetes, if they have hypertension, right? All these things factor into the prevent risk score. So if you have a high LDL alone, but nothing else, and you're fairly young, so remember the example I showed if you remember one of the earlier slides, right? I showed that you could be at low risk under 3%, but if you have a persistently elevated LDL that was, I think, above 160, then you could consider statin therapy. So and the statin, so that's in the guideline. You can consider statin therapy. Just remember that the number needed to treat is going to be not very favorable. It's going to be fairly high if the person is young and if they don't have other risk factors. And as far as high LDL, right, we're talking here about maybe in the 160 range, but we know that certainly if they have very high LDL, right, heterozygous or homozygous FH, they should be treated irrespective of other risk factors.
And you
And
can repeat the CAC score. That's another one of the things that a lot of people say. You can repeat the CAC score in a couple of years. We have a
yeah, yeah,
great.
yeah, exactly. You can repeat the CAC score. Yeah, 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 you are absolutely right. And that's in the guideline to consider repeating it in 3 to 7 years. Absolutely.
Got a great question from Dr. Mormino, which is one of my questions. So we have that same kind of patient. So what do
And
you
Patty said a new guideline in women is 45 or over. Yeah, so I couldn't remember the exact cut point. So that's right.
think?
Okay.
So what can you tell us about the oral PCSK9 inhibitors in development? Patients almost always shudder at the thought of injections.
Yeah.
Like I said,
Uh,
we do that a lot clinically. So what do
yeah,
you?
very good question. Yeah, I should have mentioned that. So there are at least two oral PCSK9 inhibitors that are fairly well along in their development. The first one is called enlicitide is going to likely be FDA approved by the end of the year, unless for some unforeseen reason. So it could actually be available by this time next year, maybe even sooner. This will be a game changer, right? Because now you have a non-statin that lowers LDL like the existing PCSK9 inhibitors in the 50% or so range, 50 to 60%. So it can definitely be a game changer. I think though people are getting used to injections more often, right? Like, especially like the GLP-1 receptor agonists for like weight loss, right? People don't seem to mind taking them for weight loss, but and most people do tolerate the existing PCSK9 inhibitors very well. But you're right, there are some that don't want to take injections. So this is going to be a game changer. There are also, what I didn't mention is, and this may be years away, but there's early clinical trials going on now with gene editing approaches for LDL lowering. So, for example, in ANGPTL3 therapy, so this is using the CRISPR technology, right? So one injection, slowly given over a few hours, but one injection, that's all you need, and it will permanently lower your LDL by 50%. So this is the future. These, potentially the future, as long as they're shown to be safe over a long period of time. But very exciting things. Also, these gene editing approaches for LP little a are being developed. So this a lot of excitement in this space. I think it's at least as exciting, if not more exciting, than when we had the statins coming out. You know, at the beginning of my career, nearly 40 years ago, you know, lovastatin had first come out, right? Then we had pravastatin, and then simvastatin, and then atorvastatin, and then rosuvastatin. Yeah, it's a new renaissance in lipid lowering therapies that will be, you know, will be exciting in the field to reduce our risk of ASCVD.
Very, very exciting talk. I think there's lots of different things in prevention. This is a new era of prevention that we're now entering, that we're actually going to make a huge difference if these guidelines and things like Dr. Wong has been talking about for the last 40 minutes actually are implemented. Any final thoughts, Dr. Wong?
Well, all I can say, well, one thing I forgot to mention is that, you know, we need to be you know, reminding our, you know, reminding our colleagues and our patients, right, to get their lipids checked, their LDL. There's a lot of people, even with ASCVD, that are not routinely getting their LDL measured at least once a year, and certainly LP little a, right? This identifies higher risk individuals. We need to get that tested. It's tested in fewer than 5% of patients nationwide currently from most recent data we have seen. So we need to bring that testing rate up, you know, and we need systems approaches to improve LDL testing and LP little a testing. We need to bring it back as a performance measure, right? Just like how with diabetes, we have annual A1C testing, right, recommended, even foot exams. Gosh, so foot exams, right, are you know, some I think even a performance measure by some. And so we need to bring back LDL testing, right? We were kind of set back 13 years ago when the 2013 guidelines came out, but we need to do that. So and I think that, you know, think about combination therapy, right, from the outset, particularly in our higher risk patients. So someone with acute coronary syndrome, we need to bring their LDL down as fast as possible, right? And it's interesting how, you know, some of my colleagues in India are ahead of the game on this, right? They did a triple combination study I was privileged to be part of, that showed the vast majority of patients within 2 weeks of their ACS got to recommended ACC/AHA targets. So I think the field needs to go in that direction.
Outstanding. Thank you. Thank you, everyone, for attending. Thank you, Dr. Wong. This was a very, very informative session on some extremely land-breaking or essentially landmark studies. So prevention studies, we're going to make a difference in prevention. We have prevention webinars every second Wednesday of the month. So we have our next webinar on July, the second Wednesday in July. Feel free to join us. We'll be talking about air pollution and the effect on cardiovascular disease, and with a litany of other talks that we're going to be doing in the future. So thank you for coming, and we hope you all join us at the next webinar.
Thank you very much. Have a good evening, everyone.
Good evening.